Hello, everyone. In our NCLEX RN review class today, we're covering important pediatric nursing topics like iron deficiency anemia, hemophilia, one, Willebrand's disease, sickle cell anemia, and B thalassemia major. So let's dive into boost your exam readiness. So let's talk first about the most common topic here, which is iron deficiency anemia, which is described as low hemoglobin levels caused by inadequate iron. And there are so many causes related to this disorder. And so we have here the following. One is inadequate stores, second, lack of iron stores or intake, chronic blood loss, and also poor utilization of iron. And so when we encounter the cost, the first cost, which is inadequate stores, this is quite similar to adults, wherein children may have insufficient iron stores if they were not able to build them up during the periods of rapid growth, or if their diet lacks iron-rich foods. However, if there is lack of iron intake, this is attributed to factors such as poverty, maybe food insecurity, there is cultural dietary practices, maybe some restrictions, or simply a dislike for iron-rich foods like meat or green leafy vegetables or iron-fortified cereals. Now, for chronic blood loss, this is related to, for example, gastrointestinal issues like ulcers. It could be inflammatory bowel disease or, let's say, intestinal parasites. In addition to that, maybe chronic nosebleeds, or it could be heavy menstrual bleeding in adolescent girls. This can contribute into the chronic blood loss as well. Now, for the poor utilization of iron, the child may experience iron absorption due to maybe medical conditions wherein they may have celiac disease or any chronic kind of GI infection. Now, let's go into the assessment findings and the most common problems that will be presented by this child patient when they come into the facility. And so they will come in with pallor. They will appear pale. The mucous membranes are quite pale when you're looking even into the oral mucosa. The sclera will you will not see any kind of pink tinge. Mostly it's very pale, and also the lower eyelid. Now, the patient will also manifest tiredness, which is very profound, and also fatigue. They will not be able to tolerate a lot of activities that most kids can do, like running, playing outside. So they will not be able to tolerate that. They can get short of breath. They would rather stay indoors and just sleep during the playtime. Now, another manifestation is pica, which is about cravings for non-nutritive substances, like they would probably crave for ice, maybe dirt, or paper. And this is something unusual for this age group. Now, another manifestation that you will encounter is tachycardia, possibly brittle, spoon-shaped fingernails. And the tachycardia is pretty much a compensatory mechanism for the body in order to at least, with a high demand of oxygen, the body will try to stimulate the heart to be much more rapid in its beat in order to compensate for the low hemoglobin level. Now, when we are looking into the medical record into our patient, now it is expected that there will be changes in the complete blood count, and it's very common that you will see right away low hemoglobin count, the red blood cell, and also the hematocrit, which will tell you the concentration of the red blood cells in the blood. It will be lower. Now, what you will see in the laboratory result is also a low iron level. Another is what we call as elevation of that TIBC. So what is TIBC? That simply means the total iron binding capacity of the blood. And so here, this is a laboratory that can measure the blood's capacity to bind iron with transferrin, which is a protein that's supposed to transport iron into the bloodstream. However, though, this can become a compensatory mechanism. So the elevation in TIBC in itself is a compensatory mechanism wherein the liver would have to make more transparent to carry extra iron to the tissues and make up for the lack of iron. So I really want you to remember the normal reference values, especially for the hemoglobin in the pediatric population. Now, I want you to recall, especially for the newborn, that the hemoglobin range for this age group, usually it can range from 14 to 24 grams per DL. And for infants, their hemoglobin range usually would be around 9.5 to 14 grams per deciliter. And for the child, it can range from 10 to 15 grams per deciliter. So I really want you to go back into those important concepts so that you will be supported in making sure that you're able to tell if there is an abnormal lab result, especially when you're given a scenario. Now, what are we going to do in taking care of this pediatric patient with iron deficiency anemia? So it is really important that we are going to provide our pediatric client with iron supplements. And this is something that can be provided to patients or pediatric patients that are preterm, or let's say with low birth weight. And this can be given to patients up until the age of 2 months. Now, also, the iron supplements can be given to full-term infants by the age of 4 to 6 months. Imagine that. And also, we can recommend iron fortified formula for infants with solids when solids are being introduced to them. Now, please remember that in order for the supplements, the iron supplements, to be absorbed by their bodies, it has to be given with oral vitamin C. Okay, this is a basic knowledge that iron supplements, oral iron supplements, should be taken with vitamin C. Let's say orange juice or any drink that is high in vitamin C content. And this is only to promote the absorption of iron in the duodenum. Now, we can also help in modifying the infant's diet to include high iron and vitamin C if they have this problem, and making sure that we are also including iron fortified formula, especially for these infants, and making sure that when providing the oral iron supplements, let's say, for example, making sure that we are limiting the intake formula to 32 ounces, or let's say 960 mLs per day, in order for them to consume the the liquid iron content. Now, we want to make sure that we are also going to encourage the parent to allow the child to take in iron-rich foods, and also to provide iron-fortified cereal when solid foods are being introduced to the diet. Now, another treatment modality would be the administration of the IV ferrous sulfate. And this is something that can be done as an inpatient in order to properly treat the child, because when a patient is given an iron IV, it's actually irritating. So it's something that needs to be monitored, and also we're going to look for possible adverse or side effects of the infusion. Now, in cases where there is severe form of iron deficiency anemia, expect that the physician might order pack red blood cell transfusion, and also possible, we want to make sure that we are monitoring the pediatric patient all throughout the treatment, especially during the transfusion process. We want to make sure that we're looking for any possible reactions. Now, let's move on to another topic here, which is going to be all about hemophilia. Now, this is quite an interesting topic wherein we are going to deal with this bleeding disorder, which is caused by the deficiency of the coagulation proteins. Now, this is associated with, let's say, a gene mutation, or it could be an X-linked recessive disorder. Now, please take note that when a condition is an X-linked recessive disorder, it simply means that the carrier are mostly females, and it can pass the defect to the male offspring. However, the female offspring are going to be rarely born with the disorder, but maybe if they can inherit, or let's say if they have that defective gene from their maternal parent, then they can also transmit that gene to their offspring. All right. Now, let us going to identify the common types of hemophilia. We have the two types, which are factor 8, which is commonly known as the hemophilia A, and also the factor 9, which is known as the Christmas disease. So please take note of that. Again, there are two types, hemophilia A, which is the deficiency in factor 8, and factor 9 deficiency, which is also known as the Christmas disease or hemophilia B. Now let's move on into the identification, or let's say how we are going to tell how is the X-linked recessive being inherited from the parents to the offspring. So let's start with figure number 1. So you will see here that the parents, especially the father, is the one that is unaffected. So he does not have any genes that has the hemophilia trait. However, you will see here that the mother has one of the X chromosome with the hemophilia gene mutation, right? So please pay attention to this. The mother has the trait, or known as the carrier, whereas the father at this point is unaffected. So for example, when they have a 4 offspring, so for example here, in our first child here, so, or let's say according to the gender, so let's consider that each son has a 50% chance of inheriting the X chromosome with a hemophilia gene mutation from the mother, because the mother is a carrier, right? So they can inherit at least 50% chance. So when this happens, when the son inherits the X chromosome with a mutation, they will have the chance to have the hemophilia because he lacks the second X chromosome with the normal gene to compensate for the mutation. So that is why you will see here that the other son might not be able to get the defective gene coming from the mom. Of course, they'll get the Y chromosome from the father. However, if the other son, the second son, inherits at least one defective chromosome from the mother, and of course, this is going to, this child will inherit the hemophilia disorder. However, though, when we are going to talk about the transmission of the defective gene when we're talking about the daughters. So for example here, also the daughter, or each daughter, will have at least a 50% chance of inheriting the X chromosome with a normal gene coming from the mother, and the X chromosome with a normal gene from the father. However, though, the daughters who inherit the X chromosome with a mutation from their mother and the normal X chromosome from their father will be carriers like their mother, but typically will not exhibit symptoms of hemophilia. So here, when we are identifying this daughter here, they're going to be carrier. They will not be exhibiting symptoms of hemophilia. However, the other daughter might be lucky enough that they're not going to be able to get the defective gene coming from the mother. So there is that 50% chance. However, though, there are some possibilities that all 4 children could inherit the normal X chromosome from their mother, and the normal X chromosome from their father, meaning none of them could possibly not get the hemophilia. So that's another possibility. Now, there's also another possibility that one or more sons could inherit the X chromosome with a hemophilia gene mutation coming from the mother, and they can end up with the hemophilia themselves. And then when they grow, of course, they're going to be manifesting signs of hemophilia. Now, there's also a possibility that one or more daughters could inherit the X chromosome with a hemophilia gene mutation from their mother and become carriers, while others could inherit the normal X chromosome from both parents. Now let's move on into another picture here, which will depict both. Actually, the father here is the person that has the hemophilia manifesting the disorder, but the mother is unaffected. So let's find out what's going to happen to the 4 offspring whenever we have this case. Now, the outcomes will be, for example, the son, since the son will inherit their X chromosome from their mother and the Y chromosome from their father, they will always inherit the Y chromosome from their father, which does not carry the hemophilia gene. So pay attention here. The Y chromosome will not carry the hemophilia gene. However, the X chromosome in the father's gene will carry that chromosome. So one of the sons here will possibly, or one or more of the sons can possibly be freed from getting the mutated gene from the father. And so the sons of a hemophilic father will not inherit the disorder. So are they lucky at this time when the sons have their father that is hemophilic, but their mother is unaffected? They surely will not get any chance of getting the hemophilia genes. However, though, for the daughters, since the daughters inherit the X chromosome from their mother and one from their father, and since the father here is the one that is affected, the father could potentially pass the X chromosome with a hemophilia gene mutation to all his daughters. Okay, and so the daughters also inherit a normal X chromosome from their mother, and so in this scenario, the daughters will become carriers of the hemophilia, but typically will not exhibit the symptoms of the disorder. So check again here. The daughters will only be carriers. They're not going to be manifesting the hemophilia. Now, let's move into another illustration here, wherein the father has the hemophilia and the mother has the mutation. So she is a carrier, and the father has the hemophilia. So let's go into the scenario now. So the outcomes could be the following. Now, the son here with hemophilia, let's put this like this. And so one of the sons could possibly inherit the X chromosome with the hemophilia gene mutation from the mother. Okay. All right. So X chromosome from the mother, they can potentially inherit that one, and the Y chromosome from the father. Pay attention here. The Y chromosome from the father does not carry that mutation, and so they will have that chance to be a hemophilic person. Okay. Now, since males have one X and Y chromosome, so if the X chromosome rather, if they inherit from the mother who carries the hemophilia mutation, they will become hemophilia. And so this outcome will usually occur in about 25% of the male offspring. Now let's move into the daughters here. So one of the daughters will potentially be hemophilic, like they will manifest the disorder. So take a look here. the father has the X chromosome with the hemophilia, if the daughter will inherit that along with the mutated gene coming from the mother, they will become hemophilic. However, this is something rare. Okay, it's about 25%. Now, we have also a daughter here that can potentially inherit the mutated gene, the X chromosome from the mother, and they can potentially will be only carriers at this point. Now, also in this scenario, there is a huge chance that the one of the sons cannot be a carrier or will not be hemophilic, maybe because they get the Y chromosome from the dad, and of course, possibly they are inheriting the non-affected or unaffected X chromosome from the mother. So they will not be able to carry the gene. They will be not hemophilic at all. So I hope that you were able to understand the different ways how the disorder is transmitted from the parents. Now let's move on into the assessment findings and the common problems that you may encounter when taking care of this pediatric patient with hemophilia. So the following problems that you might first see will be the abnormal bleeding. This is something that is commonly detected, especially at birth. So for example, when the umbilical cord is being cut, it has been clamped by, of course, there's that umbilical clamp or cord clamp, and when they cut that umbilicus, there is such prolonged bleeding at the site, or let's say there's also prolonged bleeding at the injection site where we usually give the vitamin K injection after birth. And so this is something that's usually the first time that the baby has that hemophilia. So they are detected that way. Now, another is that during the time when they may be in their toddler years or infancy, they might develop epistaxis, or let's say, for example, when they are going to be much more mobile, preschool age, or let's say school age, they will end up with joint bleeding from, let's say, injury. They are going to experience pain and tenderness of the joints. There will be swelling and also limited range of motion of that particular extremity. And then they will tend to bruise easily. So you will probably see a lot of hematoma or ecchymotic areas in their extremities. Now, when we are looking into their laboratory data, there will be prolongation of the partial thromboplastin time, which is normally, supposedly, it should only be at 25 to 35 seconds. Anything above 35 is already considered as prolonged partial thromboplastin time. So this is expected as prolonged PTT time in a patient with hemophilia. So what are we going to do here? Especially when most of these injuries happen into the school-age child or preschool children, what we need to do in this situation is to make sure we are going to assess the extent of the injury. We are going to check for the bleeding, okay? And make sure, of course, we definitely need to pressure or apply pressure to the bleeding site for at least 15 minutes. Please take note of that. This is a very common nursing intervention for us, especially for hemophilic patients. And for those patients with bleeding tendencies, we need to make sure we are applying pressure for at least 15 minutes. We gotta make sure that we are monitoring the vital signs for indications of internal bleeding or indications of hypovolemic shock. So we don't know. Maybe there is an abdominal injury caused by, let's say, maybe an accident, maybe there was a fall, or let's say there is blunt trauma to the abdominal area. So we want to make sure that we are monitoring the vital signs, and we definitely need to keep an eye on subtle changes, maybe sudden drop in the blood pressure, or let's say subtle elevation of the heart rate, respiratory rate. These are signs of internal bleeding and hypovolemic shock. Now, we're going to place the patient in a bleeding precaution, all right? So what we need to do is to prevent unnecessary venipuncture, or let's say injections, when the pediatric patient is admitted in the inpatient setting. All right. So we definitely need to avoid those unnecessary venipuncture. We're going to make sure that we are also going to monitor the patient's neuro function and intracranial hemorrhage. Now, definitely we need to immobilize the area of injury, especially we got to elevate that side to decrease the bleeding risk, and also we're going to have to apply ice into the injured site. All right. Now, another thing is we're going to have to make sure that we are monitoring any subtle changes in the neurological function of the child, especially if they probably had fallen on the floor, on the ground, or maybe they have their head on the wall. We need to make sure that we are tracking or monitoring their sensorium, their level of consciousness, their orientation as well, because if there is such deterioration, these are signs of intracranial bleeding or hemorrhage. Now, another thing is we're going to monitor them for any hematuria, all right? So if there is a possibility that maybe a blood injury to the abdominal area and could possibly injure the kidneys, hematuria could possibly happen. And so what are we going to do now for this patient that has a active bleeding? Now, one of the pharmacological agents that, or let's say treatment modality here, is to administer clotting factor 8 transfusion as ordered. So we're going to have to administer this as a blood transfusion. So of course, we're going to make sure that we have the correct order, proper dose matching. We also have make sure we monitor the patient's vital signs, assess and monitor at the start, during, and after the transfusion. Make sure that we were watching the patient for any untoward reactions to the transfusion. Now, another is the pharmacological agent known as the DDAVP, or known as the desmopressin acetate, which is the 1-deamino 8-dearginine vasopressin. So what is this medication? So this is a drug of choice, which is a synthetic form of vasopressin, which can increase the plasma factor 8, okay? And this is going to be prescribed to treat hemophilia. So please take note of this medication, DDAVP, or desmopressin acetate. Again, the therapeutic effect is to increase plasma factor 8, or clotting factor 8. Now, aside from that, we are going to teach the parents regarding avoiding, telling their child to avoid, or let's say not letting their child to engage in contact sports. That's very important. And also, especially when the patient or the pediatric patient is much more mobile. Let's say, for example, when they try to learn to ride on a bicycle or something like that, they need to make sure that they are using protective devices like helmets, or let's say knee, elbow pads when participating in sports, and also when they are trying to learn skating. So these are your teaching for the parents. Now, another would be to teach the parents about the appropriate exercise program, which will be suitable for this child that has the hemophilia. Now, let's move on into the next disorder, which is something that I have not encountered myself. But textbook-wise, this is a very common issue in pediatric population, which is the von Willebrand disease. Okay, so the W here is pronounced as the V. Now, this is a disorder that is a hereditary type of a bleeding disorder that is going to be characterized by a deficiency in the VWF factor. Okay, so here there is now a lack, or there is a deficiency in the VWF factor. So this is not a clotting factor, but however, this is a protein that is going to help out in the coagulation. So this is just this disorder basically can cause the platelets to adhere to damaged endothelium, and the von Willebrand factor protein will also serve as a carrier protein for factor 8. And so this is a disorder that is characterized by an increase in the tendency to bleed from the mucous membrane. So please take note of that. Now, we are going to identify here the etiology or the common causes of the VWF disease or the von Willebrand disease. So this is going to be in a form of, let's say, an inherited form, which has different types, the first, second, and third types. And so we're going to break down the first one, which is the inherited type. So it is considered that the person may have the type 1 inherited type of the VW disease if the patient or the pediatric patient gets the autosomal dominant type of disease, wherein there is a deficiency in the amount of the VWF or the von Willebrand factor. There is a lack in the number of the VWF. So that is for type 1. However, for type 2, the pediatric patient gets or inherits the autosomal dominant disease caused by several qualitative defects. So now there is now a problem with the quality of the VWF factor. It doesn't work as good as a normal VWF. And so it's not going to be able to really function well when there is some sort of a bleeding. Now, we also have the type 3, which is considered as the autosomal recessive disease, which has complete quantitative defect. And this is something that is going to tell us that there is no von Willebrand factor being detected in the blood. So none. There is zero flooding, or there is no VWF at all in the bloodstream. And so this is commonly observed as a person that is going to have severe bleeding. Now, let's move into the next etiology here. It can be in the form of an acquired type of von Willebrand disease. So it can be acquired through, let's say, lung cancer. And you will notice here that most of the disorders that can lead to the acquired VW disease, it's going to be CA mostly. Another is Wilms tumor. There's also gastric cancer. There will be chronic lymphocytic leukemia and also some lymphoma. And so please take note, for the acquired VW disease, these are mostly commonly going to happen in a patient that might have a prior history of cancer. Now, how are we going to identify this VWD patient? So, of course, we're going to have to look into the diagnostic studies of the chart. Of course, we're going to have to look for the complete blood count. There will be a decrease in the hemoglobin and hematocrit. The coagulation profile will tell us that there will be a prolongation of the PTT. Now, let's go into the problems here. Now, the patient, as I have said earlier, they can manifest epistaxis, nose bleeding. There will be gum bleeding. There's also easy bruising and also excessive visceral bleeding, especially for those adolescent females, right? And so these are things that really would be the mostly detected manifestations. Now, what are we going to do here next is to go back into the diagnostics here. So like I have said, one of the testings that will hint the occurrence of the VWD is the CBC. There will be a drop in the hematocrit and also the red blood cell and also the hemoglobin. However, at this point, there is going to be a normal platelet count. The platelet is not defective at this point. It is the VWF itself. Now, when we are looking into the coagulation profile, what we will usually see is that there will be prolongation of the PTT, all right? So I have already mentioned from the previous topic about the PTT range. And so here, when we are looking to the other diagnostic tests, such as the one Willebrand factor antigen, which is going to test for the quantitative defect. So here, this is going to be decreased, and this is going to indicate that there is a reduction in the amount of the VWF in the bloodstream. Now, moving into the next testing here, which is the von Willebrand factor activity, which is basically the qualitative analysis. Here, the factor itself is typically reduced, and there is some sort of a defect in its functional activity. It's not able to function normally during the coagulation process. And so we have the clotting factor 8, which is going to be decreased due to the impairment in the binding and stabilization by the von Willebrand factor. Again, the clotting factor 8 will be decreased at this point because there will be impairment in the binding and stabilization of the von Willebrand factor. Now, moving into the nursing care of our patient with the von Willebrand disease. Now, definitely we need to make sure that we are going to take care of the patient similar to the patient with the hemophilia. So you will see that I'll be saying the same things all over again. So we're going to have to assess for the pediatric patient's injuries. We're going to have to assess for the bleeding. We're going to have to apply pressure to the bleeder area for at least 15 minutes. We're going to make sure that we are going to monitor the vital signs, monitor for the joint pain, and also for the bleeding. We're going to make sure that we are immobilizing and elevating and applying ice to the site, and make sure that we are also monitoring for any hematuria if in case the pediatric patient might have sustained an abdominal injury. And we are going to have to expect the administration of the clotting factor 8 at this point. Now, also we're going to have to include the assessment and monitoring of the pediatric patient's neurological function and also the intracranial hemorrhage, possibly. So again, like I've said, check for their sensorium, their orientation, their level of consciousness. So for example, if there is now a change, a quick or drastic change from being alert to drowsy to being lethargic or somnolent. Now you've got to alert the physician about these changes, because this can give us a sign that the patient might be developing intracranial hemorrhage or bleed. Now, we are going to also expect that, also teach the patient to, or also the parents rather, that they should avoid giving any aspirin or let's say non-steroidal anti-inflammatory drugs or over-the-counter medications that has NSAID in it, because this can exacerbate bleeding tendency. So no NSAIDs, no aspirin, no ibuprofen at all for these patient with a VWD. Now we are going to also avoid intramuscular injections or any unnecessary venipuncture. Okay, so if there is really a necessity, for example, if there is a necessity for the lab technician to draw blood for lab specimen, then definitely we really need to apply, or we have to inform the lab technician to make sure that they apply pressure for the minimum amount of 15 minutes after the venipuncture. Now, for the pharmacological treatment here, again, we have our DDAVP, desmopressin acetate, as part of the treatment. Again, this is a medication that works wonders. It can induce the release of von Willebrand factor from the endothelial cells. Again, the desmopressin acetate is intended to induce the release of the von Willebrand factor from the endothelial cells. And also, this is going to be the treatment of choice for type 1. However, this is something that is less effective in patients with type 2, but this is going to be ineffective in the type 3 von Willebrand's disease. Okay. Now let's go into the next topic here, which is quite interesting. We are going to talk about the sickle cell anemia. I have taken care of sickle cell patients way before in the medical surgical setting, and apparently it was like a frequent flyer. And so I was very familiar with the patient's medical history, and so I was able to review the care that I gave from the previous encounter. And so yeah, it was good to have at least some practice, or let's say be able to engage in taking care of a patient with a sickle cell anemia. And so what is this disorder? This is an inherited deficiency or disorder in the red blood cell. Again, this is a problem in the red blood cell. Now, the problem here is that there is now replacement of the normal hemoglobin A by the abnormal sickle hemoglobin S. So please take note of that. So the hemoglobin A, which is the normal type of the hemoglobin in the body, is going to be replaced by the hemoglobin sickle cell or the hemoglobin S. All right. So how is this being transmitted? Okay, so there are going to be risk factors here. So one is being an African American descent, and also when the parents of the child will be, let's say, heterozygous for hemoglobin S. So meaning that the parents have the sickle cell trait. Okay, so we are going to define some terms here. So these are the following. We got the heterozygous gene, which is known as the HGBAS. So this is mainly pertaining to a person or a child that has the cell trait of a sickle cell disease. Okay, just the trait. Okay, so how is this happening? So the child actually inherits one normal hemoglobin gene from one parent, and they also inherit one abnormal hemoglobin gene known as HGBS from the other parent. Again, they inherit one normal hemoglobin gene from the other parent, and also they will inherit the defective HGBS gene from the carrier parent. Now, one copy of the abnormal hemoglobin gene, which is the HGBS, and one copy of the abnormal hemoglobin gene here, usually the child will not experience any symptoms. They will not manifest any symptoms of the sickle cell disease. However, though, they can pass the normal gene to their child in the future. Now let's move on into the next term here, which is the homozygous gene, which is the HBSS. So take note here, SS simply means that the child has inherited two defective genes, one from the father and the other one from the mother. Okay, so they get one bad gene from each parent. So what are we going to expect for this child? They are going to manifest sickle cell disease, SCD. So here in their lifetime, they're going to have chronic anemia. They are going to suffer pain episodes. They're going to be susceptible, highly susceptible to any infections. And also, they are going to have a high incidence of organ damage as a result of the abnormally shaped red blood cells. Okay, so please take note of the homozygous gene HBSS. And then we have lastly the abnormal hemoglobin, which is the HGBS. And so here, at this point, the child is going to both have the trait and the disease. And so they are going to also manifest the sickle cell disease through their lifetime. Now let's move on into the different illustrations on how the child can inherit, or how the parents can transmit the mutation to their offspring. So let's go into the first illustration here. So let's take a look into the father who does not carry the SCD trait. No defect in their gene. However, the mother has the sickle cell trait. Okay, so take a look here. The mother has partially is defective. Okay, so we're going to take a look into the first son here. So totally blue. The first son will inherit the normal hemoglobin gene from both parents. So basically, he is lucky enough that he was getting the Y chromosome from the dad, who is not a carrier, and he got the non-defective gene from the mother, okay, because he gets one of the X chromosomes from, or X chromosome from the mother. However, though, the second son here, you will see that they are going to be, they will be having the trait because they inherit the normal hemoglobin from the father, so partially, and they are going to inherit the abnormal gene, which is the HBS from the mother. And so the son, during their lifetime, will have the sickle cell trait. Okay. Now let's move on into the daughter here. The daughter here looks normal, right? Totally solid blue, because she gets one of the X chromosome from the father that doesn't have any of the mutated genes, and possibly she inherited the non-defective X chromosome from the mother. So she has both chromosomes here. And so the daughter would not be having any of the trait. However, though, you will see here that the second daughter will inherit one normal gene, the X chromosome from the father, and one defective X chromosome from the mother. And so she's going to be a carrier and will have the sickle cell trait. Now let's move on into the second figure here, which will give us a sample wherein both of the parents carry the trait. Okay, so both the father and the mother carry the trait. So for example, if they have 4 offspring, so please take note here that each of the child has a 25% chance of inheriting 2 normal hemoglobin genes, which is represented by HBAA, normal, right? However, there is also a 25% chance of inheriting 2 abnormal genes, which is going to be HBSS, right? So 2. Now, in the offspring, there is also a 50% chance of inheriting 1 normal and 1 abnormal hemoglobin gene, which is represented by your HBAS. However, though, there is a 0 chance of inheriting no normal or abnormal hemoglobin genes. Now, let's take a look into the first son here, wherein he inherited the non-defective gene from the father and the non-defective gene from the mother. So, of course, he doesn't have the sickle cell trait. However, when you're looking into the second son here, he inherited one of the defective genes coming from the mother, okay? And so he is going to have that HBAS. He will be getting the sickle cell trait. Again, 1 normal hemoglobin from the father, 1 defective X chromosome from the mother. So he's going to have the trait, not disease, but the trait. Now, however, though, there is also a possibility, about 25% chance that a son may inherit 2 abnormal genes, and they can become the HBSS. So they can inherit, in which they are going to have to manifest the disease. All right. Now, let's move into the first daughter here. So here we're looking into the daughter getting the defective gene coming from the mother and getting 1 normal gene from the father. And so she's going to be with a sickle cell trait. Now let's look into the second daughter here. So the daughter had inherited both defective genes coming from the father and the mother. And so she is represented as HBSS. So this daughter will unfortunately develop the sickle cell disease in her lifetime. And so that is so unfortunate. Now let's move on into the problems and the assessment findings that you will encounter in a person with hemophilia. Or I'm sorry, not hemophilia, but rather sickle cell anemia. Sorry. Now, let's go into the common problem or the pathogenesis of this disorder. And so you will see here a diagram wherein there is a comparison between the normal red blood cells and also in contrast with a person with sickle cell disease. And so here, in the normal side, you will see that the red blood cells are biconcave in shape. They are not going to have sickling. They're not going to clump together. And so there is going to be free flow of the red blood cells in the vascular system, especially in microcirculation. However, when you have a patient with a sickle cell disease, their red blood cell will tend to have that sickle trait. Of course, they're going to have that normal shape. They're going to clump together. And of course, when the blood circulates into the micro circulation, especially the capillaries and in the joints, this can cause blockage. It can cause some problems in the integrity of the bone. It can become vascular. So let's talk here about the problem here. And so in a patient with a sickle cell disease, or if they had manifested the sickle cell anemia, the sickle cell, the defective red blood cells cannot flow through the capillary bed. And then it can also increase the thickness or the viscosity of the blood. So they're going to be prone to developing thrombosis as well. Now, this is going to lead into obstruction of the blood flow. And if you're going to think about the blood flow to the major organs, or let's say blood flow to the bones, it can cause necrosis, tissue death, or let's say organ function impairment that can become irreversible. So these are expected problems that will be encountering into this patient. They will suffer a lot of pain during the necrosis. Now, of course, the oxygenation is going to be impaired to the major organs, the bone structures when this happens. So I really want you to pay attention to the problem in a patient with a sickle cell anemia. Again, look into the circulation of the sickle RBC. It can cause viscosity, increased viscosity. It can block the blood flow. It can impair the circulation, and it can impair the oxygenation of the major organs in the body. And so you will find that the person with a sickle cell anemia usually will be aggravated when they are exposed to cold temperatures, okay? And so it can cause vasoconstriction. So they are not supposed to be exposed out in the elements, especially during the winter season. This can cause that sickle cell crisis. They should not be experienced, or they should not be exposed to extreme cold temperature. Fever can also precipitate that, especially that the person can become dehydrated. There is fluid loss when there is hyperthermia. And so there will be aggravation of the sickling process and also the obstruction and viscosity of the blood. Another is that infection can trigger the sickling crisis. It will cause extreme stress into the body systems. There is an increased need for the oxygenation. There is increase for metabolic demands from the body. And so this is going to cause stress into the circulation. Same thing with the dehydration. If the person is not getting enough fluid intake during the daytime, then definitely they're going to end up with a sickle crisis. If there is insufficient oxygen intake, so it might come out in exam where in a patient or a pediatric patient might be planning into vacationing with their parents in, let's say, mountainous areas, or let's say high altitudes. They should not be supposed to exposed to they should not be going to that kind of vacation, because high altitudes usually there is a decrease in the oxygen concentration. So this can precipitate the sickle crisis. Okay. Now, another is emotional and physical stress. Again, this can increase the demands of oxygen inside the body. This can precipitate that. So we are to expect that these type of patients will experience this crisis. Now, we are going to screen the patient before we are going to identify them as having a sickle cell disease. Usually, this is going, the pediatric patient is going to screen through the sickle dex or the sickle turbidity test. So this is something that is a frequently used testing where it can be performed easily, just like when you are performing a blood sugar finger stick. So it's done similarly. So just a simple finger prick, and then this can yield results in about 3 minutes. So how awesome is that? However, though, if the person or the patient is positive for the sickle dex test, it has to be confirmed with the use of the hemoglobin electrophoresis. So now we are going to prepare the patient for this testing. So this is going to be done to distinguish the child with the trait and to distinguish or to compare those with the disease. So this will really give us a better idea if the pediatric patient has the trait only, or let's say they have the disease itself. However, though, when we are going to confirm for the sickle cell disease in this patient, we are going to employ or prepare them for the use of the transcranial Doppler test. So this is something that is not really a diagnostic as a preliminary diagnostic testing, but this is something that can be used as part of the diagnosis, especially to assess for any intracranial involvement. Or let's say, for example, the transcranial Doppler, or known as the TCD, is going to be used or ordered by the medical provider once they are suspecting that there is a problem in the blood flow involving the cranium. Okay, especially if there is a higher risk for cerebrovascular accident for this patient with the sickle cell disease, because they are really at risk to develop CVA even in their younger years. They are at higher risk to develop that. And so the transcranial Doppler is something that is going to be performed on children ages 2 up to 16 years old who have the sickle cell disease. Please take note of that. The TCD is going to be performed on children from 2 years old to 16 years old who have the SCD. Now, the other diagnostic tests that we're going to include here are the CBC, including, of course, the white blood cell count, hemoglobin, wherein there is now a decrease in the hemoglobin count because of the anemia, of course, and the white blood cell count is going to be elevated. Now, other tests it's going to include the bilirubin and reticulocyte level. So this is going to give us an idea if there is now involvement of the liver. So this is going to be seen as elevated bilirubin and reticulocyte levels because of the rapid destruction of the red blood cells. Because when they are sickle cells, we're no longer going to be able to function. Their lifespan is much shorter. So once the red blood cells that are defective, they're going to go into the circulation and will be dumped into the spleen and then will be conjugated by the liver. So if there is rapid destruction of the red blood cells, this can overwhelm the liver, causing an elevation of the bilirubin count. Now, another testing here is the peripheral smear. So this is a test that can reveal sickled red blood cells. Now, we are going to also manage the different complications in the sickle cell crisis. And there are so many. This is a very critical time for the patient and very critical for us nurses to take care of these people with a sickle cell crisis. So there are so many complications that can occur in a sickle cell crisis. So one of the following is that there will be vaso-occlusive crisis. So what is this basically? So this is pretty much the one that I've shown you in the picture where there is, let's say, increased viscosity of the red blood cells in the bloodstream. It can obstruct the blood flow. It can impair oxygenation to the major organs or to the peripheral organs. This is going to cause the stasis, the blood, the defective red blood cells will come together in the microcirculation. It can lead to ischemia. Also, it can cause infarction to the organs in the body. And so this is going to be manifested by an elevated temperature. There will be swelling of the hands, the feet, the joints. Remember that most of these red blood cells will be trapped in the microcirculation. And so the joints that are no longer able to receive oxygenation, they're going to be tender, they will swell up. And of course, if it's going to involve the abdominal circulation, there will be abdominal pain. So you got to watch out for these signs. Now, the other manifestation in a sickle cell crisis will be the splenic sequestration. So this is going to be caused by the pooling and clumping of the blood in the spleen. So like I've said again, the microcirculation of the body organs. And so this is going to be manifested by profound low red blood cell, low hemoglobin, low hematocrit. The patient here will end up with hypovolemia. Okay. Now, the person can lead into shock. This is going to be a life-threatening. We really need to place this patient on a critical watch. Make sure that we are treating the hypovolemia with transfusion and IV fluids. Now, the next complication here is what we call as the hyperhemolytic crisis. So what is this? This is caused by the accelerated, there is rapid destruction of the red blood cell over a very short time. As we know in anatomy and physiology, the red blood cells has a lifespan of at least 90 to 120 days, right? And so here, in this patient with a sickle cell crisis, their red blood cells die at a faster rate in a very short time. And so like as I have said here, there will be sequestration, there will be dumping of those dead red blood cells into the spleen and into the liver. Now, because of that rapid reduction in the red blood cell count, the patient will have jaundice. They're going to have reticulocytosis. The patient's skin will be pale. They will have very pale conjunctiva. The oral mucosa will not be pinkish anymore. And so the patient will be really fatigued. They are not going to be able to engage in activities of daily living. They become short of breath. So there is a need for us to administer oxygen as ordered. Now, another effect here is through the aplastic crisis. So what is this disorder? So this is something that is caused by the decreased production and also that increased destruction of the red blood cells. And this is going to be aggravated by, let's say, viral infection, let's say common cold or flu, or let's say the depletion of the folic acid. So please take note of that. Aplastic crisis is caused by the destruction of the red blood cells, caused by a viral infection, or it could be reduction of the folic acid. And so what is going to happen in this patient? Well, they are going to have profound anemia as well. They're going to be manifesting pallor. Of course, their hemoglobin, hematocrit, red blood cell count will be also reduced, like critically reduced. Now, please pay attention here because the sickle cell crisis will not just be confined to the 4 complications. However, the sickle cell crisis can also affect the major organs inside the body. And so it can affect the central nervous system, especially the brain. And so it can lead to a stroke, maybe because there is enough thrombosis, or let's say blockage of the blood vessels in the brain by the clumping of the sickle cells. And of course, this is going to reduce the oxygen supply to the various hemispheres of the brain. It can cause tissue damage. It can cause an infarct. And so stroke is a common complication here. Like I have said, the pediatric patient is going to undergo that TCD, that's transcranial Doppler testing, right? From 2 years old to 60 years old, you definitely need to have that testing. Now, another is the avascular necrosis, and this is going to occur in the shoulders, also the hips. It is because the bone tissue also will require oxygen. However, when there is a blockage in the circulation, or let's say a rapid deficiency or insufficiency in the blood supply to the bone, there is a lack of oxygen, nutrients. This can affect the hip area, also the shoulder joints. Now, another problem that you can encounter possibly is a patient may develop heart failure because of the chronic anemia. This can put enough stress into the myocardium, so it will increase the workload of the ventricle, the myocardium, due to the decreased oxygen carrying capacity of the sickle-shaped red blood cells. And so over time, the pediatric patient can develop heart failure. Now, there is also what we call as chest syndrome, which is going to be one of the complications wherein the person will have chest pain. They're going to have fever. They will have pulmonary infiltrates, and this can be attributed by, let's say, from an infection, or let's say pulmonary infarction, maybe, or let's say it can be as a result to acute chest syndrome, or maybe caused by a form of a lung injury caused by the sickle cell. Now, another is that their patient might develop pulmonary hypertension, wherein there is such high pressure in the pulmonary arteries. Please take note of that. This is going to happen because of the chronic hypoxia and due to the sickle cell related vaso-occlusion, which can lead to vascular remodeling, and also it can lead to increased pulmonary artery pressure. Okay, so again, caused by the thrombosis in the pulmonary capillaries. Now, moving into the next complication, which is the retinopathy blindness. This is due to the vaso-occlusion, especially in the minute capillary in the eyes, especially for those capillaries that are supposed to supply oxygen and blood to the eyes. And so if these are going to be blocked, it can cause irreversible blindness. The retinopathy is also irreversible. Now, another problem here for males is priapism. So what is this? This is going to be characterized by very painful and prolonged erection in males. And this is not related to a sexual stimulation. This only happens because of the increased blockage in the blood flow in the penis by the sickle cells. And this can lead into tissue damage, and it can potentially cause permanent erectile dysfunction. Now, I had a patient, an adult patient in the med-surg setting that had priapism caused by taking Viagra. The guy was so young, so he ended up with a surgical procedure where the glans penis was incised in order to drain the blood from the penis. So it's kind of like traumatic. So this is possibly going to be one of the surgical procedure for this child with the priapism. Now, another problem is hematuria. So, for example, if there is now involvement, that there is now damage of the kidneys, or let's say the urinary tract itself, it can lead into the appearance of the blood in the urine. Now, another is hepatomegaly. There will be enlargement of the liver because of the increased blood flow to the liver, and also increased into congestion resulting from the chronic anemia and also liver infarction, and also because of the rapid uptake of those dead red blood cells. Now, another is the appearance of gallstones. So this is going to be caused by the breakdown of the red blood cells and also elevated levels of the bilirubin produced during the breakdown of the hemoglobin. So imagine that a child with all or maybe a few of these complications. No fun. Your pediatric patient here is going to be placed during the acute phase. They're going to be placed in the intensive care unit. And once their manifestations are much manageable, they can be transferred to a regular pediatric floor. Now, moving into the next aspect of our care here in a patient with sickle cell disease is to make sure that we are to promote rest to decrease oxygen consumption. That is the main reason here. We are not going to allow the patient to do a whole lot of activities outside of bed, so make sure they are going to be placed on bed rest. Now, we are going to administer oxygen as ordered, is intended to treat hypoxia. If it's assessed that they have low oxygen saturations, of course, they are going to be low, right? And so we have to really monitor the oxygen saturations from time to time, very frequently during the acute phase and routinely when their manifestations are much more manageable. Now, we are going to make sure, expect intensive hydration. I'm not talking about like 100 mLs an hour. No. When they are going to receive intensive hydration, this is going to be boluses of IV fluids. However, though, when we are going to engage in this kind of hydration, make sure that we are monitoring critically the patient's intake and output. Make sure you do that. Have to check for the urinary output, check for the total intake, make sure that we are able to see at least normal urinary output per hour. Also, we can offer oral fluids when the patient is able to tolerate the oral fluids. We can also administer electrolytes. If there is a need to replace it as ordered, then we can do that as well. However, though, we gotta be careful when we are administering potassium, especially for those patients that may have an accompanying hypokalemia. So you gotta be careful at this point, because if the patient is still dehydrated, you're not supposed to administer potassium when the person is hydrated. You gotta make sure that the dehydration is addressed first. Because if you are going to administer potassium when the patient's dehydration is still active, this can potentially cause accumulation of the potassium in the bloodstream, which can cause hyperkalemia, and it will lead into a possible acute kidney injury. So never do that. So make sure address the dehydration first, then followed by the administration of needed electrolytes. So same thing with the potassium, magnesium. You got to be careful with these electrolytes. You got to make sure that we are addressing first dehydration status. Then you got to administer accordingly the needed electrolytes. Now, another thing that we got to make sure is to be ready about the administration of packed red blood cells. And we got to make sure that we have the proper cross matching, making sure that we are properly checking the consent of the patient, or let's say the parents. We want to make sure that we are checking thoroughly the information, the tag of the unit of the bag, checking with the other registered nurse, make sure that we are thoroughly looking into the fine details before we initiate the transfusion. Of course, we got to make sure that we are assessing the vital signs before we initiate the transfusion, during the transfusion, and after the transfusion, and also monitoring the patient for possible delayed transfusion reactions. So you got to be careful in this therapy or treatment. Now, we also need to treat the patient for infection, because they are really prone to develop infection. Now, what are the things that we can possibly provide to this patient? We can possibly administer antibiotics as prescribed. However, though, again, before administering antibiotics, we got to make sure that blood cultures have been drawn. Also, if there is also a need for us to get wound culture, possibly, then definitely get those cultures first thing before you initiate the administration of antibiotics. We got to make sure that we're performing frequent hand hygiene very carefully, especially teaching family members, visiting the child, make sure that they are doing frequent hand hygiene, especially the patient themselves. They should be doing frequent hand hygiene as well because they can also get opportunistic infection from their surrounding. Now, we can also administer oral prophylactic penicillin as ordered, and there is a possibility that can administer the patient with the pneumococcal conjugate vaccine, the meningococcal vaccine, or the Haemophilus influenza type B vaccine, because when the patient is protected with all these vaccination before the onset of the winter season, they're going to be protected from the major stresses that can potentially happen to them in case when they're going to develop all these active infections during that particular season. So make sure that they're up to date to the vaccinations. Now, also part of the care is to make sure that we are monitoring the patient's lab results. I'm talking about the complete blood count, blood cultures, also the fluids, electrolyte levels in the patient, also renal function tests. And so we got to make sure that we are notifying all these abnormal lab results to the physician or the medical provider as needed. Now, another function that we should be doing, especially in a patient with a sickle cell disease, is for the delivery of pain management. This is very important. And unfortunately, with the patient that I took care in the past, he really required a whole lot of pains, especially IV pain medications during the acute phase. Sadly, that most of the nurses are kind of like leaning towards suspecting that he is going to be, what do you call this, dependent to the medication because he's a frequent flyer at that time. And so some of them were kind of like judgmental regarding the pain management of this patient because he's been complaining a whole lot of pain during the acute phase. Now, for those patients with the acute pain, this can be managed in a variety of ways. And so if the patient is manifesting, let's say, mild to moderate pain, so the patient here can be medicated with a regular acetaminophen or ibuprofen, okay? So for only mild to moderate. We can also provide some non-pharmacologic therapy, such as the application of warm packs to the painful joints. As we know that the problem here is basically the vasoconstriction, especially for the microcirculation. The joints will be very painful, and this can be alleviated by the application of warm packs. And you got to really understand the effects of the warm packs. It doesn't have to be given 24/7. You got to remember the fundamentals of nursing and how to properly apply the warm packs. So most often, this is something that is ordered by the physician, and it has to be applied, let's say, no more than 30 minutes each time. And some of the doctors will be ordering at least 3 or 4 times a day, no more than 30 minutes each application, because it can reverse its effect. Now, we got to make sure that the patient with a sickle cell pain will receive scheduled analgesics, and this is going to prevent the occurrence of much more severe pain. And so we are going to expect the administration of a variety of medications, let's say opioids. We can administer codeine, let's say morphine sulfate in oral or IV form. It could be oxycodone, hydromorphone, IV or oral, or it could be methadone. So it depends on the patient's status and also the history of the patient if they're no longer responsive to the other medications. Now, we can administer these medications either IV or PO in some of the selections here. We make sure that there is also administration of these medications in a regular schedule, let's say every 12 hours, or let's say every 8 hours, or maybe a PRN for breakthrough pain, maybe. And some of these patients will really need some much stronger type of pain medication. So they can get the benefit of the patient-controlled analgesia, which is much more appropriate. So they can receive maybe a morphine PCA, or let's say dilaudid PCA. And so they will have some sort of independence to control their pain. But again, nurses should not neglect in taking care of monitoring the patient's pain level while we are taking care of this patient with a PCA, because there will be routine care about the patient with a PCA. We want to make sure that we are assessing the baseline response of the patient while they start on the PCA. And let's say every hour, or every 2 hours, or every 4 hours, vital signs checking, and also checking for their mentation or their level of consciousness, if they're responding to the PCA, or maybe they probably develop some kind of central nervous system depression or respiratory depression. These are things that you need to keep an eye on, especially if they're going to receive any PCA or opiate medications. Now, since we are going to medicate the patient with opiates, we gotta avoid activities that require mental alertness of the patient. So ambulation in the hallway probably would not be allowed yet at this time, okay? Because this can really impair their judgment, their gait, their posture. And so most of the times, these patients are placed on fall precaution, especially the young, right? So please be careful when you are medicating your patients with opiates. And most of the time, nurses will end up with activating the bed alarms, put them in a fall precautions, making sure that they have the family member with them when they are being medicated with the narcotic pain medication. Now, there's also another pharmacologic agent that we will expect to be ordered by the physician, which is the hydroxyurea. So this is an anti-neoplastic, which is going to prevent the formation of the sickle-shaped red blood cells, and it has the intention to decrease the incidence of vaso-occlusive events. So hydroxyurea is going to prevent the formation of the sickle-shaped red blood cells, and it will prevent the occurrence of vaso-occlusive events. So that is the main reason for the hydroxyurea. So this is going to be given in a daily dosing for most patients, and you've got to be careful in handling, because this is going to be toxic as well. Now, we are going to talk about the different therapeutic procedures that will be involved in the care in a patient with sickle cell disease. So one of the therapeutic procedures first is the exchange transfusion. What is this? So basically, the patient will undergo some kind of like exchange procedure wherein they're going to be in bed, or let's say on a treatment chair, wherein their sickled red blood cells, their defective red blood cells, will be replaced with normal red blood cells. So basically, it's kind of similar to a session in a hemodialysis session, but it's not really a hemodialysis machine. So it's going to involve with the use of the machine, the separator, to separate the sickled red blood cells from the normal red blood cells. And so the sickled red blood cells will not be allowed to return into the patient's circulation. And so the treatment will include the transfusion of the normal red blood cell to enter into the patient's circulation. So this is what we call as exchange transfusion. Now, another treatment is what we call as the hematopoietic stem cell transplant, which is going to be a much more permanent solution for the sickle cell disease. However, though, this is a critical therapeutic procedure we're in, there's a whole lot of neurologic complications that can happen. So there's going to be a one-to-one observation for this patient during the treatment. Now, aside from the therapeutic procedures, expect that the patient might end up with splenectomy, the surgical removal of the spleen. It's probably necessary for the medical or the surgeon to remove the diseased spleen because of much more recurrent splenic sequestration. There is much rapid red blood cell death being deposited or being dumped into the spleen. And so splenectomy is going to be indicated before it can rupture. Now, aside from all the invasive procedures, therapies that we are going to offer to our patient, it is very important that we are going to educate the patient, including the provision of the emotional support, because when there is a sickle cell disease, it's already going to give them a significant impact on their emotional well-being, because this is a chronic problem, okay? And so they're going to deal with a whole lot of pain episodes, a lot of complications. And so providing them with emotional support can at least help the patient to cope with the stress, anxiety, also depression, and also possibly going to improve their quality of life. And it can also give them some kind of adherence to the treatment. And so we are going to also refer the child to social services. And so they are going to, so that they're going to be able to access to comprehensive support, okay? They will be able to get some kind of external support, let's say, for example, resources that will address their unique needs. Now, another is that our patient will need education regarding what to tell if there is manifestation of infection, or let's say when a sickle cell crisis sets in. So they need to be taught on describing what these manifestations are so they can notify the medical provider promptly. And so make sure that they can recognize promptly the manifestation so that when they are being sent to the medical facility, there will be rapid medical intervention and also the reduction of the complications. Now, also here, we are going to allow the patient to have adequate grass nutrition, because this is going to be helpful in managing the sickle cell disease and will reduce the risk of the complications. Now, the patient will also need maintenance in a balanced diet, making sure that they stay hydrated all the time, they're getting enough sleep, and they need to avoid those factors that can contribute or trigger the symptoms. Now, another thing that we need to educate is about hygiene, because this is going to really reduce the spread of infection, especially for those patients that may have a compromise in their immune system. So make sure that they're not allowed to expose themselves to crowds and to prevent themselves from being exposed to infected individuals, especially for colds, flu. Never allow them to be exposed to those persons. Another would be having them avoid people, like I've said already, infections, avoiding crowds, make sure that they have adequate fluid intake, and also they have to be up to date in their immunization. So make sure that they have that yearly for, let's say, flu shots, or let's say pneumococcal vaccination per schedule. We want to make sure that they're up to date. Now, another thing that we need to make sure they have is the wearing of the medical alert band, which can provide vital information about a person's medical condition. And so if in case they'll be found down somewhere, and so this can at least tell the responder to what precautions that they should be doing when they respond to this patient, let's say become unconscious. Now, another thing is that we have to educate our child, patient, or let's say the parent, to avoid any contact sports. And so make sure that
they understand this pretty well because this can really reduce the risk of injury and also reduce the vaso-occlusive episodes in individuals with sickle cell disease because they can never tolerate any strenuous activity or exercise where they're going to engage in a lot of fluid loss, a lot of sweating, physical activity. They're not going to be able to tolerate these things. So make sure that they understand the limitation that they have. Now, we are going to talk about the next problem here, which is the thalassemia major, beta thalassemia. So this is a problem that is characterized as autosomal recessive disorder, which simply means that the pediatric patient will be inheriting this from both parents. And so both parents are supposed to be carriers in order to produce a child with a thalassemia B major. Again, this is an autosomal recessive disorder. And so the pediatric patient will be getting this from both parents. So let's move on here. And so what is going on here is that there is somewhat kind of a reduction in one of the globin chains in the synthesis of hemoglobin. And so this is a problem that is common in Italians, Greeks, also Syrians, and for those Mediterraneans, mostly people in the Mediterranean with Mediterranean descent. And so you are going to see this occurring mostly in these people. Now, please pay attention here because in thalassemia, there are different types. And so we got to make sure that we understand which one is which. And so there are different types, starting with thalassemia minor. So what does that mean? It simply means that the patient is asymptomatic silent carrier case. So they do not manifest any of the manifestations. They are a silent carrier. However, when they are considered to be with a thalassemia trait, the person here will produce mild microcytic anemia. And so their red blood cells are known to be really small in size. And so this is what we call a thalassemia trait. Now, the third one is what we call a thalassemia intermedia. So what is this? This person will manifest enlargement of the spleen and also moderate to severe anemia. Okay, so basically the blood, the red blood cell here is very defective, microcytic. It's not going to be able to last longer as it should be. Remember again the normal lifespan of the red blood cell. Now moving into the thalassemia major, which we will be talking about more in this discussion. This is a type wherein this can lead into much more severe form of anemia, which will require mostly transfusion in order to support life. And so this is what we also call as the Cooley's anemia. So again, the beta thalassemia major is also referred to as the Cooley's anemia. Now, we're going to have to deal with the different diagnostic tests that will be used to identify this patient with beta thalassemia major. So what are these diagnostic tests? Now, please remember here, since the problem is with the red blood cell, the complete blood count should capture the following. There will be small red blood cells. There will be microcytic hypochromic anemia. So it simply means that the size of the red blood cells are quite small. And the tinge or the color of the red blood cells is pale, hypochromic. And there is that decrease, there is reduction in the hemoglobin content. So that is why it's going to give the red blood cell a characteristic pale color. It lacks pigment. And so in the CBC, you will see that there will be decrease in the hemoglobin levels. There will also be decrease in the mean corpuscular volume, or known as the MCV. And so the MCV, when it is decreased, it simply means that the size of the red blood cells are small, microcytic. Now, another test here is the reduction in the MCHC, or known as the mean corpuscular hemoglobin concentration. So what is this? It simply means that there is low hemoglobin content in each red blood cell. So it gives that low or pale tinge color in the red blood cell. Okay. Remember, microcytic hypochromic anemia. Now, another diagnostic here is the hemoglobin electrophoresis. What is this? So in this scenario, the patient with a beta thalassemia major will have increase in the hemoglobin A2, which simply means that there is increase in, or there is such a suggestive beta thalassemia trait. Now, there is now an absence or reduction in the hemoglobin A, which is the normal hemoglobin. Now, another testing that we will be expecting is so please take note here again in the hemoglobin electrophoresis, increased HbA2. Okay, so the patient will be diagnosed with a beta thalassemia major if it's greater than 3.5%. Now, also the patient will have absent or reduced hemoglobin A, which is the normal. Now, another testing here is what we call the peripheral blood smear, which is going to have that anisocytosis or the poikilocytosis. Basically, the red blood cells have abnormal shapes, which is going to affect its integrity. It's not going to be able to last long as compared to the normal red blood cell. Now, what we are going to expect in patients with the beta thalassemia major. So you got to watch out for this, because these pediatric patients would have characteristic traits. Their appearance will be so much different because they will have that what we call as frontal bossing. And so you will see that there is now protrusion of the frontal bone of the skull. And so that can be really easily recognized, right? And so there is a prominent head or forehead. And of course, with the beta thalassemia major, this is going to happen as a result to the expansion of the bone marrow as a compensation of the chronic anemia. Okay, and so the enlargement of the bone structures, especially the forehead, it happens as to compensate the low chronic hemoglobin, or let's say chronic anemia, and that is why it's starting to compensate. It's going to grow fast to cope with erythropoiesis, to promote the production of more red blood cells. And so that is why there is now increase in the size of the skull. Another is the maxillary prominence. And so the patient's cheek will have that characteristic facial bone structure. And the same reasoning, like I have said, when there is frontal bossing. This is a compensatory mechanism of the bone structure of the cheek. Now, another is the wide set eyes, flattened nose. And so you will recognize this. And this is caused by the alteration in the facial bone structure, and also, again, brought about by the chronic anemia and also the expansion of bone marrow, particularly in the craniofacial region. Now, this patient will also have a characteristic greenish yellow skin tone because of the patient actually will have rapid destruction of the red blood cells. And so there is now increase in the bilirubin content in the bloodstream. That's why they're going to have a greenish yellow skin tone. So please pay attention to the different bone malformations of the patient with a beta thalassemia major, the prominence of the forehead, the maxillary, both right and left. Same thing with this girl, the nose area, and also we don't have a picture about the green tinge. Now, there is also hepatomegaly, enlargement of the liver, in response to the increased production of the blood cells. This is as a response to the chronic anemia. So the bone marrow will be stimulated to produce faster. However, though, there is also excess iron accumulation, and this can occur in the liver. And so this can cause enlargement of the liver. Now, another is splenomegaly. And what is causing the enlargement of the spleen? Well, this is something that is triggered by the hematopoiesis, extramedullary hematopoiesis. And this is caused by the other major organs that can cause the red blood cells. However, with the rapid destruction of the red blood cells as well, like hemolysis, this can trap the normal red blood cells within the spleen. That's why they will have enlargement of the spleen. And so there will be abdominal tenderness in the left side of the abdomen for the splenomegaly, and for the right upper quadrant of the abdomen for the hepatomegaly. Now, your patient will have severe anemia, so they will have that characteristic pale color, and also they lack color, especially in the oral mucosa. You will rarely see them with pink tinge because of the lack of hemoglobin. Now, because of the microcytic and hypochromic red blood cells, this can really cause some changes in the overall picture of the patient. They are going to be generally pale. The nail beds are really pale. Often you will see some kind of like a spoon-shaped nail beds as well because of the chronic anemia. Now, what are we going to do for these patients with thalassemia major? And so one of the things that we can provide to this patient is to give blood transfusion. Mostly it's the packed red blood cell. And again, you're going to have to observe proper cross matching, checking with another RN regarding the blood product, the order, also the vital signs be monitored before, after, and during the procedure, and making sure watching for any untoward adverse reactions from the blood transfusion. Now, another is that we're going to monitor the patient for iron overload because of the frequent blood transfusion. And so we want to make sure that we are monitoring that. And also this can be treated by the use of the deferoxamine or let's say a chelating agent to reverse the iron overload or iron toxicity. Now, another is the surgery, which is going to be the surgical removal of the spleen, splenectomy. And so we are going to educate the patient and the family post-surgical procedure as well to properly take care of the site, and also to make sure that we are educating them about the vaccination status, especially for the pneumococcal and meningococcal vaccine. And that's it. The surgical site should be checked carefully post-surgical. Now we want to make sure that the dressing is kept dry and intact, and we have to keep an eye daily regarding the characteristic of the wound incision. If there's any redness, if there's edema, or let's say there is now drainage, there is now a change in the order of the wound, and also if there is now a spike in the white blood cell count in the laboratory, we want to make sure that this is notified to the physician right away in order to address possible infection, and followed by, again, maybe with a treatment of the use of antibiotics, blood cultures, before initiating the antibiotics. And so that's pretty much it about the beta thalassemia major. And so understanding pediatric blood disorders like iron deficiency, anemia, hemophilia that I just taught to you, the von Willebrand's disease, the sickle cell anemia, and the beta thalassemia is very important for you to study before you take the NCLEX exam. And so recognizing each disorder traits, the assessments, and also the treatments will help you provide better care for the young patients in the future so that you can get better outcomes in your patient care. So keep an eye out for more helpful tips to boost your nursing skills and ace the NCLEX-RN exam. And so I'll see you again in the next video series. Thank you and have a great day. Bye-bye.